recording this session, so it
Yep.
will be available after today's
Thank you.
session.
Just let me know, Jess, when everybody has been admitted so that I can start.
So, yeah, there's no one left in the waiting room, Rani.
Okay, thanks. Let's kick start then. Hi, everybody. Thanks for joining us for this third webinar we're doing as part of our educational program based on the learning needs analysis we conducted across West Yorkshire. So today we're going to be talking about the National Lipid Pathway and how to navigate it. And in particular, we're going to be giving some case studies to discuss. So to set the scene, I'm just going to talk about just a reminder and a refresher about the National Lipid Pathway. And my colleagues today, Abi Barrowcliff, Harpal, Ryatt and Sara, Hafidh, will be presenting some cases. And they're going to show you how they would manage those patients based on the National Lipid Pathway and different elements of it. Next slide, please. Next slide. So the National Lipid Pathway was put together so that we have a standardized national summary of how we should approach lipid management. And this pathway contains within it all the different NICE guidelines and technology appraisals, all in double-sided A4 sheet. Is quite busy, but the idea behind it is that you are able to identify all the different elements that are scattered within the different guidelines and technology appraisals in one single document. By no means we expect you to read this document every time that you need to manage a patient, but you are highly advised to familiarize yourself with the different sections of this pathway. The front of the pathway basically has got the following. The top header there, where it says initial considerations, is all about the things that you need to be thinking about when you want to manage patients' lipids. It is all about the baseline bloods that you need to order, thinking about full lipid profile every time that you do lipid optimization, not just the total cholesterol, because you want to understand the bigger picture. And it talks about you thinking about what are the potential contributing factors to high cholesterol, need to ensure that they are well managed, such as if somebody's got poorly controlled diabetes, somebody who's got hypothyroidism. So these kind of the tests that we're alluding to. So it gives you a bit of an idea of what are the baseline tests that you need to be doing. The next element when you embark on the pathway is to decide which of the three columns are you in. First of all, are you in the green column, which is primary prevention? That's somebody who has not been diagnosed with established cardiovascular disease. Or you've got the red column, where you've got somebody who has got established atherosclerotic cardiovascular disease. And the definition of that is somebody who's got ischemic heart disease, somebody who's got angina, somebody who's got peripheral vascular disease, stroke, transient ischemic attacks. All these would class somebody with established atherosclerotic cardiovascular disease, and then you manage them from the red column there. The green column is somebody who hasn't got a diagnosis of cardiovascular disease, but they're a higher risk. And they're higher risk either because their Q risk is high, or they've got conditions that put them at high risk of cardiovascular disease, such as type 1 diabetes with additional risk factors as defined in the pathway, or somebody's got CKD. And it tells you, the pathway tells you how to escalate therapy in order to optimize lipid management in those patients. And the idea behind these different boxes that you see there is ask you the question of what should be using as first line, what happens if the patient doesn't meet target or threshold, and how do you escalate therapy. The middle column is all about when you've got somebody with severe hyperlipidemia. So when to suspect that somebody could be having FH, familial hypercholesterolemia, how to assess for it while you're managing them as secondary or primary prevention. So this is just telling you that if somebody's total cholesterol is more than 7.5, somebody's LDL is more than 4.9, you need to start thinking, could it be FH? It may not be, but it kind of asks you, suggests for you to do additional tests and checkings that you need to do. So the pathway thereafter, it just goes through what the escalation of therapy and how to keep checking with if patients are meeting the threshold or the targets. And the back of the pathway, next slide, please. It has multiple boxes there, and they're meant to guide you through how to manage those patients. As I said, highly advised that you actually familiarize yourself with the content. As I said, you don't have to keep reading this every time you're managing a patient, but at least you know which part to look at. The left column talks about general management, talks about primary prevention risk assessment, the do's and don'ts when you're using Q-risk, which population automatically classed as high risk, which populations need Q-risk, and that's in the special patient populations there. The middle column there talks about what kind of extent of reduction you're likely to get from different lipid-lowering therapies, and the likelihood that for you to meet target, which is highlighted in the third column, the top there where it says titration thresholds and targets. Then you've got the monitoring element. What do you monitor in addition to full lipid profile? When do you monitor transaminases, and how often you should be doing that? If any, what happens if the transaminases are slightly high? Is every elevation transaminases count or not? It's all detailed in there. And then it talks about the use of injectables. When do you refer somebody to have PCSK9 monoclonals? When do you use other therapies when you want to manage triglycerides? It gives you a bit of an idea of when you need to refer, when not, after you've excluded things. And it talks about the statin tolerance. This is overall what the pathway is trying to do, and hopefully the next cases that would be presented to you will give you an idea of how you would navigate this pathway. So I'll hand over to my colleagues who will present to you some cases, both from secondary and primary care, just to show you how we navigate the pathway. And we have questions at the end, of course. Thank you. Over to you, Abi.
Thanks, Rani. Thank you. Good afternoon, everybody. My name's Abi, and I'm an advanced clinical pharmacist in cardiology with a specific interest in lipid management. So I'll provide a brief introduction to our Cardiology Medicines Optimization Lipid Clinic and then present 2 case studies. So we all know that hypercholesterolemia is a significant risk factor for cardiovascular disease, and that the lower that we can get a person's LDL cholesterol, then the better the outcome for the patient. Any patients with severe hyperlipidemia should be assessed for familial hypercholesterolemia and referred to the appropriate clinic. So do not wait for the outcomes of clinic before treating. I think that's #1 importance here, because untreated, 30% of women and 50% of men will have a premature MI. So we've got the Simon-Broom criteria, which provides a clinical diagnosis, and the Dutch Lipid Clinic network score assesses eligibility for genetic testing. So I'll briefly talk about the purpose of our clinic. So it was set up in 2017 following the publication of NICE TAs 393 and 394 as a centralized service prescribing PCSK9 inhibitors. But our purpose isn't solely to offer treatment with the injectables, but to provide a holistic, patient-centered approach to lipid management. So in the time that we've been running this service, we've produced papers and abstracts highlighting the successes of the clinics in terms of patient outcomes, and we've been identified by NICE as a model service for the delivery of PCSK9 inhibitors and lipid management in general. So I'll move on now to therapy options very quickly. So we are really fortunate now to have several therapy options available to manage cholesterol. Up until about 20 years ago, we would have had statins only. So each of these options have varying eligibility and criteria, which can cause some confusion. So the National Lipid Pathway was produced, which helps guide and support decision making. And here it is again. So moving on to my first case study. So Ms. J is a 68-year-old woman who was referred to us via the endocrinology-led lipid clinic following a clinical diagnosis of FH. She was labelled as intolerant to statins and had just been initiated on ezetimibe. Her baseline untreated LDL was 8.2 millimoles per litre. So as with all new referrals, she was introduced to the service and a general discussion was had around lipid management, including the importance of it, therapies available, and lipid lowering targets. We explored her statin intolerance in more detail. So she suffered in particular with hair loss, which we know is a known side effect of statins, but she was also having trouble with forgetting words. Now, Miss J worked as a translator and therefore she was not keen to risk a re-challenge of statins as it impacted on her work. So as she just started the ezetimibe, we agreed that she would complete 3 months on it and then we would assess for response afterwards. So what are our initial thoughts? What are we treating, primary, secondary prevention, and what are our targets? So let's go back to the pathway. So because we are treating severe hyperlipidemia, in this case, we're looking at the middle column. So as per the pathway, we would manage her as primary prevention with an FH diagnosis. Her target, according to NICE, would be a reduction in LDL cholesterol of at least 50% from baseline. So other sections that are worth looking at in terms of primary prevention for FH, we've got risk assessment, and it's important to note that we would not use Q risk 2 or 3. We've got the titration threshold and targets up there on the top right, and then we've got the eligibility around PCSK9 inhibitors as well. So again, important to note, we do not need to wait for the outcome of genetic testing before we start treatment. To us, we are treating her as a clinical diagnosis of FH. So her next appointment was a bit later than intended, and her LDL had reduced by 11%. So is this what we would expect on ezetimibe monotherapy? Is it enough? So we would expect maybe about 15 to 20% approximately of reduction in LDL in a person on ezetimibe. So it is a bit lower than expected, and it does not meet that 50% reduction that we need or would like. So we decided to question that, go into a bit more detail, and Ms. J was struggling to remember to take the ezetimibe. And the decision was made at this point in time to stop ezetimibe. So this automatically rules out treatment with bempedoic acid. So next on the list to think about are inclisiran and PCSK9 inhibitors as the 2 injectable therapies available in the UK. Inclisiran is not an option for Ms. J, as the NICE TA only recommends its use in people with established cardiovascular disease, i.e. for secondary prevention. The NICE TA for PCSK9 inhibitors recommend treatment only when LDL cholesterol is greater than 5 millimoles per litre when we want to use it for primary prevention in an FH diagnosis. Ms. J's was well beyond that, so treatment with alirocumab was offered and accepted. So before we initiate, of course, we'll provide all the counselling, we discuss self-administration, how that would be educated on, and then any potential side effects. In our experience, it's generally very well tolerated, both PCSK9 inhibitors, but the most common side effects include congestion and fatigue. And again, these are generally self-limiting. We use a home care service to provide delivery and education, especially while we've been using telephone consultations over face-to-face, but we're hoping to move back to more face-to-face consultations in the future. So unfortunately, after 6 months, the LDL had only reduced by 26%. So why could that be? So we would normally expect about a 50 or 60% reduction in LDL cholesterol in a person on PCSK9 inhibitors. So we had to do a bit more investigating. So after discussing with Ms. J, she'd only had a first injection at the end of August, and therefore the October bloods may have been slightly premature. We checked with adherence and she had no issues there, and she wasn't suffering from any side effects, which is good. The plan was made at this point in time to continue the alirocumab and to repeat bloods. So the bloods were repeated and the LDL cholesterol remained below the recommended target levels on repeating. So we had to have a think about what to do next. So we need to contemplate the possibility that Ms. J is a non-responder to PCSK9 inhibitors. We discussed the possibility of adding ezetimibe back in with extra support on how she can improve adherence to that oral medication and what she can do to help her. She didn't have any issues with it in the past. It was simply that she was forgetting to take it. So we could offer support on that. Again, she was happy to try that, and we requested for the GP to add the ezetimibe back in. And there we go. We've got a 49% reduction when the full lipid profile was rechecked in February 2023. So with a 49% reduction, NICE target has pretty much been met. But 4.2 millimoles per litre is still quite a high LDL. You may find some patients are given a hard LDL target, for example, of less than 2.5 millimoles per litre. We know that the lower the better. So we discussed whether Ms. J was interested in further lipid-lowering therapy, and we also delved a bit further into how she was managing with her diet and lifestyle. So she has no issues around lifestyle. She had a good diet, and she was not interested in adding any further oral therapies at this point, but did remain open to it in future. At this point, if LDL was to raise or if she changed her mind, then that's when we could consider adding in bempedoic acid. So this process took nearly 3 years and 5 appointments. So on reflection, could we have been more aggressive with treatment in the beginning? Should we have started PCSK9 inhibitors immediately? Should we have supported ezetimibe adherence and continued it alongside PCSK9 inhibitors rather than stopping it and having to add it back in? However, what we don't know at the beginning of all of this is we didn't know she wouldn't produce a full response to PCSK9 inhibitors. There were a few issues around timing because of a lack of availability of blood results. And I mean, essentially, sometimes this process just takes time. So it's really important for us to build and establish trust in our patients, to listen to their concerns and preferences for treatment. And if we do that, I think we are more likely to get a better outcome for our patients. So long term, Ms. J is going to stay under our care now, and we will continue to prescribe PCSK9 inhibitors, and we will continue to monitor her lipid-lowering therapy and her full lipid profile on an annual basis. Oh, I'm getting all mixed up. Sorry, everyone. So my second case study is Mr. D. So Mr. D was referred to us from primary care. He was on no statin therapy or any lipid-lowering therapy at all, having reported intolerance to statins in the past. He has no interest in re-challenging. That was very clear on the first appointment. So his baseline untreated LDL cholesterol was 4.2 millimoles per litre. With an LDL of greater than 4, he was eligible for and initiated on evolocumab. So because we are managing Mr. D, who has got established cardiovascular disease, we're looking at the secondary prevention. So we're looking at the red section on the right, and we are aiming for an LDL cholesterol of less than 1.8 millimoles per litre. So at his next appointment, the efficacy of evolocumab was assessed, and the reduction of LDL-C was 60% from baseline. He had no adherence concerns, and he had no complaints of side effects, which is fantastic. However, if we have a look at his triglycerides, in November 19, they were 1.9. In April 2020, they've gone up slightly to 2.3. So let's have a bit of a think about that. Are we concerned? Do we need to start icosapent? So we need to have a think about that as well. So in terms of the triglycerides, they are slightly raised. And so what we would do for the next full lipid profile that we took was to ensure that we took a fasting sample. We also need to rule out any uncontrolled diabetes and any excess alcohol as a cause. So in this case, Mr. D has a BMI of 33. So an adjustment in lifestyle factors and losing some weight would hopefully help lower these triglyceride levels. I just want to point out here that we would not initiate a fibrate. I would never initiate a fibrate. And after speaking to the endocrinology lipid clinic, they would only ever initiate a fibrate in very specific circumstances. So we would not expect or recommend a fibrate be initiated in primary care regularly. So if you've got any questions or any concerns about anything, please come, send us an advice and guidance. We can support with that, but a fibrate is often not the answer. In terms of icosapent ethyl, that's one of our most recent lipid-lowering therapies recommended for patients with a high triglyceride and a controlled LDL cholesterol. However, it should only be offered to patients who are on a statin, so it is not appropriate for us to start it for Mr. D. So my reflections on this. So compared with Ms. J, we got to target far quicker. We started one medication, he got a 60% reduction, and we're where we wanted to be. So I feel like this case further highlights different needs and responses for each individual person, and that not one process suits all. And another thing to note is that in this scenario for Mr. D, inclisiran would have been an option, but it wasn't available at the point in time that we offered PCSK9 inhibitors. And in those patients who were tolerating and responding well to PCSK9 inhibitors, we wouldn't switch. If both had been available at the time, what we do with our patients is we discuss both. If a patient or a person is eligible for both injectables, we discuss pros and cons of each. We delve more into the beliefs of the patient and what they want from their therapy, and then we make a decision based on that. But it wasn't appropriate for Mr. D as it was too long ago. So those are my two cases and my reflections on them. I believe we're doing questions at the end. Is that right?
Yes, we are. So just to reflect with you on these cases, yeah. Abi. So in the first patient, I guess it was a potential FH, and it was primary prevention. Statins was not an option.
No.
Ezetimibe was offered.
Yes, and she took ezetimibe for 3 months. Yes, initially.
And probably would have not brought it down any near the 50%, would it?
No, it wouldn't.
So probably we need to be thinking where we're going in terms of target when we prescribe this. And it's interesting, she was a non-responder, indicating that we shouldn't fire and forget, and that you never know. Some people. So the figures that we quote for a lot of these medicines in terms of the expected LDL reduction is not necessarily always going to be seen in all patients.
No.
And she was an example. So that's a very good example there. And thanks for highlighting that Curix should not be used if you're suspecting FH, because I have seen patients with MI where they were excluded from any therapy because Curix was used wrongly. And they had potential FH, and 15 years later, they were admitted with an MI. So thanks for highlighting all those.
I also find this section really useful, Rani, the lipid lowering with statins. I feel like this is a really good resource to use when you're trying to decide whether you should be increasing a statin or whether adding in another oral therapy. Just gives you an idea of what sort of reduction you're going to get. So I find this section very useful.
Okay. So the other options, I guess, we had for this one is inclisiran is not an option because it's not indicated in primary prevention at the moment, according to NICE. And the other option would have been bempedoic acid with ezetimibe, but it's not likely to give a reduction as high as you'd get from PCSK9s. But even PCSK9s did not get that on their own. So combination therapy is probably the way forward. But what would be another option then if you want to intensify therapy for this lady after you've got your nearly 50%?
On top of the ezetimibe. So PCSK9 inhibitors, ezetimibe, you could then at that point add bempedoic acid, or alternatively, we could re-explore the possibility of a low-dose statin. But obviously she wasn't too keen because of the impact it had on her translating work. But we find that patients who may not be able to tolerate a higher dose of statin might be fine with a weekly dose of Rasuva. And that might just be enough to help bring the LDL cholesterol down a bit further.
Yep, sounds good. And then your next case, it was interesting. Secondary prevention. I guess at this point, I know that when you offered this patient the PCSK9 inhibitor, so you went straight to PCSK9 inhibitor.
In this scenario, yes.
So was that your logic for trying to meet targets? Because if you've offered this patient only ezetimibe, they probably would have not reached target.
Yeah,
Is
exactly.
that the logic you use?
Yeah, so this is a scenario where you're having where we've looked at what reduction we need and what medication we have available to try and meet that target. Now, we would discuss this with the patient as well, because, you know, this is a patient-centered service. So we would give them that information. And, you know, ezetimibe is still open as an option for them, but you do find that sometimes they would prefer to go straight for the treatment that they know is going to bring their cholesterol down the most and hit targets soonest.
So this patient would have qualified for inclisiran as well, because it's secondary prevention. From your experience, what kind of logic or preference patients and you have over choosing between the two, either inclisiran or PCSK9 monoclonals?
So it really varies from patient to patient. I think for me, you know, we have the cardiac outcome data for PCSK9 inhibitors, which is a big pull to the PCSK9 inhibitors. However, if you have a patient who doesn't want to self-administer because of a needle phobia or because it makes them uncomfortable, then being able to offer treatment with inclisiran is so valuable. So we have patients that tend to go for the PCSK9 inhibitors, tend to be attracted by the cardiac outcome data. They're attracted by the flexibility of self-administering. They're attracted by the fact that we've got more patients on it, that it's been around a little bit longer. Whereas the patients that go for inclisiran tend to not want to inject themselves. They like the idea that it's twice a year, and the pull of no reported side effects is also really big for inclisiran as well. So I very much find that it's very patient dependent on which they're going to go for, and I can never quite predict what they're going to pick.
What about adherence? Because I come across some patients where probably they find it quite convenient when it's twice a year, especially if they're struggling with adherence.
Exactly, yes. What we've also done in the past, if there's an issue with adherence, or maybe they're getting bruising that they don't like, taken every 2 weeks, it's also worth remembering that we do have alirocumab 300 milligrams that can only be that only needs injecting once every 4 weeks. So that's always a useful option too. Adherence is definitely a big pull for them.
Right, excellent. Thank you so much for your time.
Thank you.
We'll have a chance for more questions. Please use the chat and Q&A if you have more questions. Move on to Harpal, who's going to present us also a case. Over to you.
Harpal, do you want to take over from me?
Yeah, does it work? I think I do.
Have you got control now?
Let's give it a go. It says I have control.
Does it still look right to everyone? Do you want me to?
Maybe I'll just leave it. I'll just let you know when to move slides.
Okay, let me know.
All right.
I'll open it back up.
Thank you. Brilliant. So hi everybody. So I'm Harpal. I've got a sort of a dual role. So I'm a PCN pharmacist and I'm doing a secondment with LTH to do lipid optimization with PCNs. So the reason why I chose this case is a typical primary care case that you might come across. So it's a patient that's been on a statin in the past and now on ezetimibe and have been forgotten. So you might find cases like this that have been picked up in your QOF or maybe UCL partner searches. So you can go to the next slide, please, Abi. So this is the case. So let's call him Alan. So Alan is a male, 63, he's a non-smoker. His past medical history includes an STEMI. As well as this, he's got gout, so that's not helped by his poor diet and alcohol intake. Medication-wise, so he's on the typical medicines you'd see for secondary prevention and gout prevention, and he remains on ezetimibe 10 milligrams once a day. Lipid profile, so it's last done, his non-HDL was 4 and his LDL-C is 3.5, so he's not to target. So if we can go to the next slide, please. So looking at the pathway, we're on the right-hand side, which has been mentioned earlier. That's the secondary prevention, and we're roughly just below the orange box. So the patients are on ezetimibe monotherapy because they've not been able to tolerate statins, and they've just sort of been forgotten about. So if we can go to the next slide, please. So what resources can we use? It's got one of those animations, obviously you might have to keep clicking. Resources, as mentioned previously, you've got the national guidance. The top right there, on the second page, as Abi mentioned earlier, you've got each statin and the rough sort of approximate LDL reductions that can be achieved by each statin. On the bottom row there, you can see when you add in ezetimibe, you can get roughly a bigger decrease in your LDL as opposed to doubling your statin dose. So it's just something to be aware of. Another resource you might need for this type of case is the statin intolerance pathway. So on page 1, which is the bottom right above the arrow, that part is good for you using the pathway if you're challenging someone else already on a statin and they're experiencing muscle pain. So it guides you through which tests to do, such as CK. And then on the second page, which I've zoomed into this box here, this part talks about how you can use rosuvastatin and atorvastatin at weekly dosage because they've got long half-lives. So if we take these resources and go to the next slide, please, Abi. So looking back at Alan, so the first thing we'll do is make sure he is definitely secondary prevention. So I've got that confirmed in letters. So that's particularly important if we're looking at a patient and maybe looking at inclisiran treatments. The second thing would be just to double check diet, lifestyle, alcohol intake with him. This can help with obviously cholesterol and gout, and make sure we're checking adherence as well with the current medicines. And then in terms of lipid lowering therapies, so as part of a shared decision with Alan, so we discussed his options and find out which is the most appropriate one for him. So the first option would be, can we give him a long-acting weekly statin? So he's had muscle pains on statins in the past. It's not clearly documented roughly what those muscle pains are. So the option we've discussed with him would be maybe try rosuvastatin once a week combined with ezetimibe. The second option for him on the pathway would be bempedoic acid, but this is not an option for him because he's got a history of gout. And then the third option on the pathway would be inclisiran. So because his LDL is above 2.6, he's got a confirmed secondary prevention. He's eligible for inclisiran, but he dislikes injection, so that was a complete no. So we've gone for option 1, rosuvastatin. So as part of that conversation, it's an empowerment. So obviously he's had muscle pains in the past, so it's about speaking to Alan and explaining that you can start off by taking a 5 milligram once a week. You can have this tablet 40 milligrams once a day, so that helps give people comfort that they know this is a very, very small dose. You can pick it any day in the week to take it and then continue for a month. If he's fine after a month, has no side effects at all, he can stick up to twice a week for the second month and so on, just continue to build it up. After 3 months, we'll do a blood test and see whereabouts we are. And obviously before starting a statin, we'll do the liver function tests as well, just to make sure they're okay. So in our post-intervention results, we've got a really good response. His LDL-C has dropped from 3.5 to 2.1. So it's definitely working, and that's just taking it twice a week. So if we go to the next slide. So what do we do next? So obviously we've not hit the target of less than 1.8 LDL or non-HDL less than 2.5, especially for QOF. So we can continue to titrate to the maximum tolerated dose. So that might be 4 times a week he's able to get to. We'll then repeat the blood test after 3 months' time again and LFTs and see whereabouts we are. And it might be that he is able to achieve target just taking it 4 times a week. He might take it every day. And if he does have experienced any side effects, it's important that he just drops down to the lowest tolerated dose. So if he was good at 3 times a week, but he suffered pains at 4 times a week, it's important to stay at that dose rather than stop it completely. That's the end of my case. So we'll go on to questions at the end. Thanks,
Harpal. Just a couple of comments. In terms of option for this patient, clearly the patient is not interested in injectables. From your experience, how many patients do you come across who would say completely no to injectables, roughly?
Yes, so I'll probably say in about 30 cases of inclisiran, we've only found one in sort of leads, comparing two PCNs in leads. So it's been very, very good uptake in the injections, and people have responded quite well to the sort of lack of long-term safety data.
Right. And regards to bempedoic acid, we know the issue of it raising uric acid, and therefore the issue of higher risk of gout. Is it though contraindicated in patients who had a history of gout, or is it just a caution?
So I think it's a contraindication. It's on the BNF. I can remember correctly. It's going to increase that.
Yeah, I think most cases in the trials, it did raise uric acid, but not all patients who had uric acid went on to develop gout. So at the moment is caution. Was this patient on any gout controlling medicines?
Allopurinol, yeah.
Okay. So if we were to be stuck and the patient can't take a statin, of course, we shouldn't be combining bempedoic acid with high intensity statins generally. But if the patient's stuck on statins and don't want to try it at all, would bempedoic acid and ezetimibe be an option? And what monitoring would you probably be doing if you were to do it? It's actually a caution, not a contraindication. What additional monitoring would you be doing if you were to go down that route?
Yeah, so you might want to do baseline urate levels and then possibly repeat that after between 1 to 3 months time when you do repeat LFTs, and then counseling the patient just to make sure they're aware if any signs of gout to report that as well as the diet and lifestyle advice to avoid food high urate.
So it is actually, yes, I think there's a lot of studies showing not everybody who had uric acid went on to develop gout, even if they had a background of gout. So it can be an option, especially if they've got allopurinol, but I wouldn't go down that route unless absolutely necessary, of course, as you rightly highlighted. But yeah, 25% is not enough probably for somebody who's in NSTEMI, would like to see his LDL nearing to 1.8. Another thing from injectables, from our experience, usually people have perceptions about injectables, but when you actually show them the injection and that it's not going to be a really massive torture or anything, they tend to ease their fears, but not all of them. Still some do reject them. That nicely moves us on. Thank you, Harpal. To the next case. Over to you, Sara.
Hi, everyone. I'm Sara Hafidh. I work in 2 PCNs across Wakefield. I'm the lead pharmacist, and 3 days a week I work as an advanced clinical practitioner. So we're going to look at a case study. 72-year-old male. Thanks. He's got a history of ischemic heart disease. He had an ST elevated MI in 2019 and has a heart valve disorder. So he's on secondary prevention medication. Amlodipine to manage blood pressure, aspirin, atorvastatin 80, bisoprolol, perindopril, lansoprazole. He's got his GTN spray. He hasn't used it in quite some time, which is quite good, and bimatoprost. Can we go to the next slide, please? So we did some blood tests for him. So he was identified via QOF to us, given the work that we need to do in primary care. So full blood counts were all normal. He had a kidney function blood test, which was normal. Thyroid was normal. So it's really important to monitor thyroid levels when we're doing cholesterol management. HbA1c was normal. Serum cholesterol was 6.1. His triglycerides were elevated to 2.1. High density lipids were good. LDLs were 3.9. And cholesterol HDL ratio is 4.8. And because of QOF, obviously, we are needing to achieve a level of LDL of less than 1.8 or non-HDL of less than 2.5. I reviewed his alcohol intake, which was quite low, occasional alcohol consumption. BMI was all right. So When I spoke to the patient, he confirmed that he was taking his medication regularly, and this can be supported by looking at his historical cholesterol levels and seeing whether there has been a significant drop from his original levels. We then discussed diet and exercise. His triglycerides were a little bit elevated. We explored things that he can do to try and improve and manage it. We then discussed options in terms of managing his cholesterol. So we know he's on atorvastatin 80 milligrams. So bempedoic is not an option because of the high intensity statin. We then explored ezetimibe and inclisiran. When looking at kind of like the LDL levels at 3.9, it is quite a big jump to getting it less than 1.8. So I did explain to the patient, these are the two options that we have. Inclisiran is known to reduce up to 50%, and ezetimibe, we also discussed that. So we were looking at it in more of a harsh, let's get it done quickly. And then if we don't achieve the LDL levels, we can then add in the ezetimibe. So we've got another option in case we don't achieve target. So patient was happy to commence inclisiran. I think the selling point for him was because it's twice a year, he doesn't need to take a tablet regularly. It reduces kind of polypharmacy for him. So I think that kind of sold it more for him. Can you go through the next slide, please, Abi? And then obviously looking at the national guidance, if we look at the secondary prevention, I've just highlighted it and it's completely blurred, so you guys can't really see it. But it gives you the breakdown options of what you can introduce to the patient. So obviously we've gone for the third box, which is the injectable therapy. And because his LDL was above 2.6, we could introduce the injectable as per NICE. So we did do his blood test, and this is post his first injection. So this is just before the 3-month mark. Bear in mind, he's due his injection probably next week now. So bloods show that the total cholesterol decreased by 34%. His LDL decreased by 64%, which was absolutely fantastic. So when we did discuss it with the patient, he was absolutely relieved that we don't need to do a further add-on therapy. Because the way I explained it to him is that we need to manage cholesterol as if we're managing any other medical condition and try and achieve the lowest point by add-on therapy. So he had in his mind that he actually was going to have an add-on therapy. So he was really relieved, and hopefully he'll be injected next week for the remaining kind of management for his inclisiran. Yeah, that's it.
Excellent. Thank you so much, Sara. So just reflecting about the adherence element, you put there in the comments that you've kind of looked at historic cholesterol levels. Do you want to elaborate a little bit more about that and the usefulness of not just relying on one reading in terms of establishing if the patient is actually potentially could be adherent or non-adherent? Do you want to just share your logic again about that element?
Yeah, so if you're asking a patient, do you take your medication? They're always going to tell you, yes, I take my medication. But a good way to kind of look at it, because obviously they will be ordering it every month as normal. The best way to look at it is prior to them starting their statin or any other therapies, look at their cholesterol level, and then obviously review it year on year to see if it's actually coming down or it's dropped from the original baseline. And that's a good way to show whether they are adhering to the medication or not. And patients are human, you know, they're going to have blips where they take it and they don't take it, or they forget it. So you'll see a slight kind of alteration in their cholesterol levels, but they should be trending down rather than up. But that's a good way to kind of confirm adherence.
That's good, thank you. The other thing that comes to mind, have you got a few of your patients using inclisiran, or?
Yes. So
I'm just going to ask you if people have been having any issues, have they reported any problems, or have you been taking people off? I just wondered what your experience of using inclisiran in specific, because it's the newest drug that we have, apart from ecosapentethol, I guess. Just wondered what your experience. Anybody else also welcome to chip in if they've got anything to add. Yes, go ahead.
So across the 2 PCNs, it's 11 practices, so it's lots of fun, lots of work. It's just under 100,000 patients, and I think we've injected about, I want to say, just over 80 across the 2 PCNs. Out of the 80, I think there was one patient in for each of the surgeries, 1 out of 4 surgeries, one patient in each of those 4 surgeries refused to take the second injection because they felt absolutely shocking. And it took them 2 months to kind of feel better. We did try and kind of challenge it and reintroduce it. One patient actually was reintroduced. She was happy to try it again to see, but the other 3 completely kind of said no. I did have one patient that had a sensation of itching for a week after he had the injection, but it completely resided and he was happy to have his second injection. And I did say to him, if you do have it again, please let me know because I need to report it. But he hasn't said anything yet, so I'm assuming it was just a blip.
I was going to ask next about bempedoic acid, but I've got somebody who's got their hands up. Do you want to go ahead, Helen? Not sure if you can speak.
Yeah, I think, can you hear me now?
Yes,
Yes.
Go ahead.
Yeah, I've just got 3 quick questions really, hopefully. One was the inclisiran. Are we able to prescribe that in primary care, or is it something that we should be referring for?
No, you can prescribe it in primary care. There's nothing that stops you from issuing it as long as it's within the NICE guidance and the patient's LDLs are 2.6 or more.
Right, okay. And then my second question was bempedoic acid with high statins. Why is that? Why can't we give it with high statins? I didn't know that.
I'll pass it to Rani.
So the logic behind that is statins work by inhibiting the HMG-CoA enzyme, which is basically reduces the production of cholesterol in the liver. And bempedoic acid just works above that pathway, doing the same thing. And the logic goes that if you're already on a full dose, high intensity statins, the likelihood that the additional reduction in LDL cholesterol that you're going to get when you've got a very good inhibition of the pathway is going to be minimal. So it's not probably cost effective. For that reason, it isn't usually recommended for combining with high intensity statin in specific. So the NICE guidance is very clear that bempedoic acid should be prescribed with ezetimibe. And the reason for that is because bempedoic monotherapy doesn't produce more than 15 to 20% reduction in LDL cholesterol. If you combine it with ezetimibe, you're going to get probably a decent 40 to 45% reduction of LDL cholesterol. Now, if you add it to our full high intensity statins, it's not likely to produce significant reduction compared to ezetimibe monotherapy. There is a debate whether you can combine it with low intensity statin. That hasn't been covered by the TA. It is outside the TA. In some cases, which patients probably need it, we can consider it, but that will be outside the NICE TA. But it can be considered, but not with full dose high intensity statins, because the additional benefit is likely to be minimal compared to low intensity statin. I hope that clarifies it. You had 3 questions, Helen. Did you ask all 3?
Well, the only other one was the icosapent. I think Abigail mentioned that you can have it for high triglycerides if the LDL is controlled. There was a case, but then there was another reason why you just couldn't give it in that gentleman. I couldn't remember what that third reason was.
The icosapent NICE TA recommends that you only give icosapent in someone who was on a statin. Okay. So it's only for patients who are on statins, as well as meeting all those other eligibility criteria.
Okay, that's it. Thank you.
So we've got a few questions for you guys on the chat. So Eunice is asking, how was the patient feeling after second inclisiran injection? Had the side effects resolved?
Yeah, so the ones that refused to take it, obviously they didn't take it, and that was 3 patients we said. But the itching patient, he hasn't complained of any side effects till date, and I think it's been just over a month that we've given him the second injection, so he was aware to call back if he got it. So I'm assuming everything's all right.
Good, thank you.
Yeah.
And then there's a question here. Can you clarify about over 85 years old in primary prevention? what is the evidence in offering them all atorvastatin? The pathway suggests that if we offer a statin, frailty should be considered, should still be chasing a target in this age group.
Happy to answer that one, Rani. I work with a lot of care homes, so do a lot of patients that are 80, 85, 90, 95. So we regularly see them being admitted to hospital and they'll come back with a discharge saying statin stopped, no clinical appropriateness. So I think that's it's an individual decision. So we need to know whether or not this patient is expected to be here for 1 year. Is this person expected to be here for another 10 years? I have started statins on patients that are 85 and that are 90 and restarted them after the hospital stopped it because they've got no expected prognosis in the next year. You know, you got to think that they're going to be around for the next 5 years. We're doing it as both primary prevention and for secondary prevention. So if they've tolerated statin in the past for the past 10, 15 years, they've had no effects on their LFTs, their cholesterol has come down, then there's no sort of reason why they can't have it. So I think it's an individual decision. You can't blanket saying don't give it to anyone over 85. They can do it on a case by case basis.
I think patient preference is also huge in this age group as well.
Yeah.
So yeah, very good point from you all. I've got somebody raising their hand. Yeah, go ahead, Mittal. Are you not able to?
I think he's muted.
That's better. Yeah, sorry, it was me that asked the question because, like you said, a lot of elderly consultants will stop statins because they'll say there's no evidence for it. So I'm presuming because it's on the pathway there is evidence for it, or is it an extrapolation from younger people that they're using? And the second bit of my question was, if you do start it in a 95-year-old, do I check their lipids in 3 months and make sure the statin's working, or is that pointless? Because I don't want to. I think I'm asking, what is the benefit of this drug in this age group? Are we just guessing that because it works in younger people? And then if we start it, do we check it in 3 months, because the pathway seems to be exactly the same for a 99-year-old, for example, as it would be for a 45-year-old. Is that right?
Yep. So there's a historic reason for this age, and the historic reason is that most clinical trials have excluded patients of that age group. So the evidence base that we have seems to be more in the people less than 85 years old, and that's why all the guidance is not as robust when it comes to their age. However, we always say this, and it's very important to remember this statement: the absence of evidence is not evidence. The fact that there is no evidence in clinical trials is not in itself evidence. It just simply means that there is an ambiguous area that we need to exercise clinical judgment when it comes to it. And there are a lot of observational data showing benefit in patients above that age group. So there's plenty of published data looking at observational outcomes from using statins of those over the age of 80, 85, showing benefit, especially in secondary prevention. So we can rely on that as not robust evidence as of course, randomized control trials, but it is some indicative evidence that there's probably potentially benefit. I think it boils down to discussion with the patient and coming to something that suits them. I have seen patients in my clinic who are 86 years old and even 90 years old, and they're fit and well, not frail, and they're up and going, and they want to take their medicines and they believe in it. And I've seen people who are younger than that, who actually were very frail, or probably would be rationing their medicines and actually offering them, which I think is best for them. So I think there is a clinical judgment in there based on shared decision making with the patient, with transparency. And I wouldn't make a flat out statement that everybody above a certain age to stop it. I don't agree with that. With regards to checking levels, I think in secondary prevention, you may want to consider it. But you need to be pragmatic probably about it, about where you're going. But I don't like fire and forget in case something else happens. You'd be doing bloods anyway to look for any potential side effects. You'd be doing full, like example, LFTs, you'd be doing other tests. So having an idea what somebody's full lipid profile is is a good idea. What you don't want is, if the level of reduction is completely insignificant, then you want to revisit, because there's no point of exposing somebody to a therapy that doesn't seem to be producing sufficient benefit. And we don't necessarily have to be as strict as we are with all the other targets, but I think you need to balance it. So it's not unfortunately black and white. It's a bit of a grey area, but it needs to be more of clinical judgment exercised alongside with the patient being part of that decision making. Sorry, others been answering here. Any other questions I missed? Conscious we've got 2 minutes.
I think the last one from Sumaya would, for secondary prevention and previously stopped by elderly care home hospital admission, would we be going for high intensity statins, or would like you would in younger patients? So secondary prevention.
Would we be going for high intensity statins as we would in the younger population in secondary prevention? If it's after an acute event, then usually, so the evidence base for acute event is slightly different for somebody with stable coronary disease. So let's be clear about that. So the use of high intensity statins at full dose is more in acute setting. So if somebody has an acute coronary syndrome, we put them in a full dose high intensity statins that, based on the clinical trials, was showed that those patients do better than lower doses of high intensity statins. So if we compare 20 milligrams of atorvastatin versus atorvastatin 80 post ACS, atorvastatin 80 was better in terms of outcomes. And we think that's probably goes beyond just the lipid lowering element. However, the evidence for stable coronary disease is slightly not as robust, and there is room for probably using lower doses if we worried about reduced renal function, if we worried about frailty, then there is a bit of room to think about that. That would be kind of my practical going about it, conscious that we're running out of time, probably run out of time. Is there any other questions?
There was just one question about full dose statin ezetimibe, and then cardiology have recommended adding in bempedoic acid. But I think that's definitely a discussion that you should have with cardiology, because the NICE-TA doesn't recommend the use of bempedoic acid in addition to a high dose statin, so because of the reasons that Rani outlined earlier.
No, we wouldn't recommend it. It's not in line with the guidance, and I would like to see what additional reduction they're going to get, probably minimum. And also there is the risk of interaction with statins. So bempedoic acid does interact with the statins as well. Okay, I think that's the end of our session. Thank you very much. Thanks for the speakers for the brilliant cases they presented, and thanks for everybody who attended. And hope to see you in the next webinar, which we have in December. We shall be advertising. Jess, are we giving a feedback form? Are you emailing people?
Yes.
You can put a link probably in here. Sorry, Jess, go ahead.
Oh, sorry. I was going to email everyone afterwards, along with the recording for today.
All right. Okay.
So yeah, you're gonna get to thank you all as well.
Okay, great. So you guys gonna get feedback forms. Please do complete them. That gives us an idea of what you're looking for, so that we can tailor our session towards your needs. Thank you so much. Thank you, everybody.
Thank
Well done.
you.
Thank you.
Bye.
Thanks.
Thank you.